Great. So we are now, I'm handing over to the next segment of the program, and I'd like to invite our panel members up to the stage. I'd now like to call on Professor Anthony So, who directs the Strategic Policy Program for REACT Action on Antibiotic Resistance and Johns Hopkins Center for Livable Future, to lead the panel discussion. Professor So is a respected expert on the issue of AMR. He has served on the Lancet Infectious Disease Commission on Antibiotic Resistance and the Institute for Medicine's Committee on Accelerating Rare Disease Research and Orphan Product Development. He's also chaired the WHO Working Group on Antimicrobial Resistance and was part of the Antibiotic Resistance Working Group of the US President's Council Advisors in Science and Technology. So after the 5 panelists' presentation, we will hear also commentaries from 2 esteemed experts, Dame Sally Davis and Dr. Keiji Fukuda from WHO. And then Professor So will moderate a Q&A discussion, interactive dialogue with all of you. So Professor So, over to you.
Thank you, Nana and Lord O'Neill, for setting the stage for today's discussions so ably. True to the title of this briefing, our panelists will address the multisectoral challenge of antimicrobial resistance. Each brings a unique perspective, and we hope that their remarks in composite will provide a useful context and perspective, as well as years, if not decades, of relevant experience, both on the important recommendations laid out in the UK Review on AMR and in other proposals put forward by key stakeholders who have worked on these issues. Now, no doubt, we cannot do justice in the space of 2 hours to the full spectrum of perspectives that rightly deserve a place on this panel: healthcare delivery systems, academic research centers, the pharmaceutical industry, drug regulatory agencies, agribusiness, and of course, the providers and patients, as well as others. Many, of course, of these perspectives are represented in the audience, and we hope to have an opportunity later in their session for their interventions. But we do trust that this briefing will help advance the discussions already underway on the road to a high-level meeting on AMR at the time of the UN General Assembly this September. Antimicrobial resistance threatens the progress towards attaining several Sustainable Development Goals, and these implications go beyond healthcare to, of course, food systems and the environment. We will only achieve meaningful universal health coverage and reduce the burden of communicable diseases, both under SDG 3, if our patients have access to essentially effective antibiotics and if we all conserve the use of these life-saving drugs. And we will only have a system of responsible, sustainable consumption and production under SDG 12 if we can curb the non-therapeutic use of antibiotics. As Nana mentioned, we will have a panel of 5 speakers, 2 of whom will focus on the issues of innovation, access, and conservation, issues that typically fall more so on the human side of antibiotic use, and the balance of the speakers who will address the use of antibiotics on the agricultural side. The panel will be followed by reflections from, of course, our 2 distinguished discussants, Dame Sally Davies and Keiji Fukuda. Now, in setting the stage for our first 2 speakers, I would like to outline a few key principles. The effectiveness of our response in meeting the challenge of antimicrobial resistance rests on our ability to address the tripod of innovation, stewardship, and access. On innovation, we have to bring truly novel and effective classes of antibiotics to market. What we have in the R&D pipeline clearly falls short of what we will need. What has come onto the market has too often disappointed not only healthcare providers, but also the industry. Between 1980 and 2009, over 40% of systemic antibiotics were withdrawn from the US market. And most of these were withdrawn not for safety reasons, but probably because they were little value added against existing drugs. The rate of antibiotic withdrawal from the marketplace is over 3 times greater than other therapeutic categories. So when you hear of the low returns among antibiotics, those averages reflect these withdrawn antibiotics as well. Of note, 2 first-in-class antibiotics, linezolid and daptomycin, came to market before new incentives were in place, and both command impressive prices. And despite market sizes in the range of 140 to 180,000 patients per year, well below the orphan drug cut point, these 2 drugs have sales that place them among the top 100 US drugs on the marketplace. Not bad positioning for these truly novel first-in-class antibiotics. If one studies the R&D pipeline, though, for antibiotics, a fundamental challenge remains: the upstream scientific bottleneck. After all, the dearth of novel antibiotics begins with drug discovery, and there's a 10-fold lower yield in the drug discovery phase of identifying promising drug leads when comparing antibiotics to all other therapeutic drug categories. On stewardship, drug companies face the economic conundrum that a breakthrough antibiotic would be conserved. That is, we in the healthcare system would only want them to use it sparingly, only when absolutely necessary, lest drug resistance emerge rapidly to its use. The promise of a small market is understandably not a winning value proposition. And the final part of the tripod, access. If these drugs are not available nor affordable to those in need, patients will not benefit, and there will not be fair returns on the public investment to bring such drugs to market. So the principle of delinkage, separating the returns on investment from volume-based revenues on a drug, or in other words, from price and quantity, has emerged. The UK review on AMR has put forward a rich set of proposals to address some of these concerns. These include a global innovation fund for early stage and non-commercial R&D, late stage market entry rewards, as Lord O'Neill had mentioned, a pay-or-play proposal for the pharmaceutical industry, and top-up payments for diagnostics for low and middle income countries. On innovation, we might ask, do these incentives help transform the innovation ecosystem for antibiotics? Or are we still hoping that company by company, drug by drug, to enable the private sector to deliver new antibiotics? Will these incentives lead to a system of sustainable production and consumption of antibiotics? On stewardship, what incentive approaches might enable us to delink return on investment from volume-based revenues so that the economic incentives in the system line up with access but not excess? And on access, do these approaches move us towards a more equitable system of distributing and delivering affordably these life-saving drugs to those in need? To help us think through these issues, I'm delighted to invite Precious Matsoso, Director General of the National Department of Health of South Africa, and Rohit Malpani, Director of Policy and Analysis of Médecins Sans Frontières Access Campaign, to offer their reflections. We have asked each panelist to keep their remarks to 7 minutes. Not to take away from their time, may I refer you to the program where their bio sketches will show the depth and breadth of their expertise they collectively bring to the topic before us. Drawing on years of experience in various roles, including chair of the WHO Executive Board, member of the UN High-Level Panel on Access to Medicines, and former WHO Director for the implementation of the Global Strategy and Plan of Action of Public Health, Innovation, and Intellectual Property, may I now invite the Honorable Madame Matsoso to offer her reflections.
Good afternoon. AMR is a global problem. It needs a multilateral response. It needs no visa. It knows no boundaries, no borders. Professor Ramanan, indeed, it needs a collective response, and in particular, a multilateral response. But we also need public health measures. We must address social determinants of health, community-based interventions, as well as health systems-related interventions. And those health systems-related interventions are about fostering innovation and facilitating access. In facilitating access, we need to ensure therapeutic access. Therapeutic access is about ensuring that those medicines, those antibiotics, those antimicrobial agents are available in pediatric form for children. They're available, but also they're restricted in use. They cannot be widely available because increase in availability is also a problem on its own, in that increase means increase in consumption, and increase in consumption means increase in sale. So we have to deal with both barriers to access, barriers to innovation, whether they be scientific, technical, regulatory, legal, administrative, as well as some of the measures we've seen in some of the countries with regard to litigation. And with regard to litigation, we've seen 2 newer antibiotics which had to be withdrawn from the market precisely because of that. There's been a plethora of innovative ideas, including in the review report, of coming up with mechanisms of funding. But I'd like to raise 3 specific issues that require attention. That these plethora of initiatives on funding for antimicrobial research and development required coordination. And in coordination, we must set up some governance structures and mechanisms, ensure that there are some principles that deal with transparency as well as sustainability, long-term sustainability. And in achieving that, we'll ensure that some of these financial barriers that we see can be addressed. But of importance, we need to ensure that, and I would like to use the South African example. In South Africa, I actually say that we've got a triple burden of resistance. Resistance to HIV because we've rolled out treatment to 3.4 million people, resistance to TB treatment, anti-TB drugs, and resistance to antimicrobial agents. So with that triple burden, we have to ensure that we address each instance and also each particular area differently. Differently because with regard to TB and HIV, the problem is not that of access. The problem is that of scaling up. You need to put more people on treatment. With antibiotics, it's the different problem. It's about misuse, it's about excessive use, so you need to contain excessive use. So we have to approach these problems differently. And I'd like to raise that for other countries, of course, because we want to leave no one behind within the context of the Sustainable Development Goals. We have to deal with social factors. Social factors are not just about sanitation, clean water. It's also about immunizing children and ensuring that affordable vaccines are available. It's also dealing with overcrowding with regard to tuberculosis. It doesn't help to treat TB when it continues to be spread because of overcrowding. I would like to say that we welcome the proposals that have been highlighted in the review report, particularly financing, and to emphasize that we need to ensure that there's coordination, because there is also a BARDA initiated by the US, there's a GARD that has just been launched, which is led by DNDi, and also a whole lot of other initiatives, if we can just create that mechanism of coordinating. Secondly, advocacy. I wouldn't agree more that this is a society-wide response. Because it is a society-wide response, it requires a response by everyone. And in that regard, we'll be able to respond. Let's ensure that there's open source so that we can support innovation. Let's promote partnerships so that there can be product development partnerships, both in developed and developing countries. And let's promote the principle and concept of de-linkage so that medicines can not only be developed, they can also be accessed, they can be affordable, particularly for those who need them. How quick we use this and how quick we respond will be able to reduce the burden of disease. Let me warn all of you in this room. 1/3 of the world population has latent TB. So half of you, or 1/3 in this room, have latent TB. So let's all respond and ensure that we can be treated timely with appropriate treatments. Thank you.
Thank you, Madam Matsoso. Your remarks remind us of the challenge in moving life-saving antibiotics from bench to bedside. Certainly the importance, of course, of maintaining the right formulations for children. Certainly the challenge is certainly right safeguards for both safety and, of course, conservation, the need for coordination, financing, and also considering that the different manifestations of resistance and how we might deal with these issues. May I invite Mr. Rohit Malpani to offer his reflections from his wealth of experience as the former senior campaign advisor at Oxfam and his current role as the Director of Policy and Access for the Access Campaign at Médecins Sans Frontières.
Thank you for providing MSF the invitation to speak. MSF is an independent humanitarian organization providing impartial medical assistance in more than 70 countries to people affected by wars, natural disasters, disease outbreaks, and economic exclusion. Drug-resistant infections are a looming challenge for our work today. We see them in the war-wounded people we treat in Jordan, in newborns in Niger, and in people in our burns unit in Iraq. Our medical staff is increasingly seeing people with infections that can only be treated with the last lines of antibiotics. There are many challenges to address in tackling antimicrobial resistance, and MSF welcomes the AMR Review's broad global approach. The report confirms what MSF has long voiced, that the current system of pharmaceutical research and development, based on monopolies and high prices, does not develop and deliver the drugs, vaccines, and diagnostics we often need. And when new medical tools are developed, they are often unaffordable or not suitable for the people and contexts which need them the most. So we'd like to make 5 observations for today. First, although we welcome efforts to foster new investments and approaches to research and development for unmet needs, these measures will not have any impact unless governments and the World Health Organization assume the central role in identifying gaps, guiding priority setting, and ultimately managing new research and development funding. We think the report could have issued a clear recommendation supporting such a mechanism. This matters to us since only governments can ensure that the needs of neglected and vulnerable patients are not left behind. The report highlighted the need for new drugs and diagnostics to address TB. Yet we cannot be confident that despite the significant morbidity or mortality associated with the disease, that it will be appropriately prioritized. This is due to the fact that TB, simply put, is especially prevalent in low and middle income countries. So if we introduce a system of priority setting based on who can pay the most, or exert the most influence, or simply leave it to companies to decide, we will simply reinforce the failures of the current system of research and development and not correct them. Second, even as we acknowledge efforts in the report to highlight the importance of access, urgent action that goes beyond the report's recommendations of voluntary action, in particular government action, is required to expand access to existing drugs and vaccines. Today, more people are dying for lack of access to existing appropriate drugs and vaccines, not from drug resistance. The pneumococcal vaccine, or PCV, which is sold by only Pfizer and GlaxoSmithKline, is one example of an unaffordable vaccine. Even in the poorest countries, PCV accounts for approximately 45% of the total cost to vaccinate a child. Why does PCV matter? PCV protects against pneumococcal disease, which kills approximately 1 million children every year. It is estimated that universal coverage of PCV could result in a 47% reduction in antibiotic use in people with pneumococcal infection. Today, just under a third of people globally are protected with PCV. To maximize the potential of this vaccine, we need dramatic price reductions and competition. Third, while MSF welcomes the efforts of the report to identify and propose alternative models of research and development, the report at times does not propose models that truly safeguard affordable access for new medical tools. In particular, the report does not always fully support delinking or separating the cost of research and development from sales volumes, and most importantly, the end product price. Delinkage is often limited in the report to particular diseases or only applied to low and middle income countries. This means that even though new drugs may be conserved, they may not be affordable for all people. Companies could be paid at least twice, via market entry rewards of approximately $1 to $1.5 billion, and a second time through an opportunity to sell drugs at higher prices. The report proposes slightly different models to develop new diagnostics and vaccines, yet as with Gavi's advanced market commitment, the proposed subsidies may not be efficient nor safeguard affordable access. One example where the report supports delinkage in its entirety is a mention of a new model of TB drug development that MSF has championed, the 3Ps project, also known as push, pull, and pool. We think this is an effective way to deliver short course, less toxic, and affordable combination treatments for all forms of TB. Fourth, we stress the importance of policy coherence. We note that alongside the UN Special Session on Antimicrobial Resistance, the WHO continues to advance government-led efforts on research and development through the Consultative Expert Working Group, and the UN General Assembly may consider a new report being written by a UN high-level panel on access to medicines, which was commissioned by the UN Secretary General. The high-level panel seeks to recommend solutions to the broader research and development crises of unaffordable prices and a lack of innovation to address priority health needs. We hope missions in New York connect the dots between these three processes. Finally, we are concerned that global health security is driving our fight against antimicrobial resistance. While such a framing may be an effective means to call governments to action, It can lead governments to focus on solutions that only seek to protect their own people, rather than ensuring affordable, effective, and appropriate medical interventions for all. We welcome the report for building attention to this problem, and we hope that government action at the UN Special Session in September and beyond will ensure coordinated political commitment to make urgent challenges to introduce a new global R&D framework that puts patient needs first. Thank you.
Thank you, Mr. Malpani. You clearly called out, I think, some very important issues, the need for priority setting, particularly to ensure that particular diseases such as TB are in fact dealt with appropriately, to expand access actually to complementary technologies which could decrease the selective pressure on drugs such as vaccines for pneumococcal disease, and the importance of alternative models such as 3Ps that could be financed actually through the opportunity of working on antibiotic resistance. Importantly, also note the issue and importance of policy coherence, which we can see clearly as we see several processes now converging, which include the CEWG process and resolution recently adopted at the World Health Assembly, the work of the UN High-Level Panel on Access to Medicines, and the upcoming UN High-Level meeting on AMR in September. So we will see a convergence of a lot of these issues, as well as, of course, the importance of beyond the impetus that global health security might give us the initial momentum, that we must, of course, consider this in the larger context of those whom we are trying to actually deliver antibiotics so that their needs will be met. Our first two speakers have highlighted some of the key challenges and opportunities ensuring innovation, stewardship, and access, how the UK review on AMR proposals might support these goals, and where we might go further or even take some different directions. Our next three speakers will offer insights on how antibiotics might be used more sustainably in the food production system. Antibiotics have a dual market, both in humans and in animals. What is widely recognized is their resistance to a drug used in animals can confer resistance to bacteria in humans. And there are several routes for this transmission from animals to humans. This, of course, occurs through contaminated food products to consumers, but also can be transmitted to workers along the food supply chain. Resistant bacteria can also spread through farm waste and runoff, or be carried by flies, rodents, and even migratory birds. There are no borders that contain the spread of drug-resistant bacteria. We all recognize the importance that antibiotics play not only in treating diseased animals, but ensuring a healthy, sustainable food system. However, the use of critically important antimicrobials for growth promotion, for prophylaxis, for offsetting poor hygienic conditions, risks squandering these precious societal resources. To be clear, it will not be enough to just curb the agricultural use of antimicrobials important to human medicine. Other antibiotics not used in human medicine can cause cross-resistance to those medically important drugs. Of great concern, an analysis commissioned by the OECD, the Organization for Economic Cooperation and Development, projects that global antimicrobial consumption of food animal production will climb by 67% between 2010 and 2030. Of this increase, 2/3 will come from a larger number of food animals in production, meeting the increasing need for meat consumption in our world. And 1/3 of this increase traces to the transition to a more intensive animal production system, where thousands of animals are kept in high-density facilities, conditions where antibiotics have been used in greater amounts. Most worrisome has been the emergence of resistance to colistin, a drug used as one of the last-line defenses against drug-resistant infections in human medicine. This past November, investigators reported the startling finding in China of plasmid-mediated resistance to colistin. They had noticed an increase in colistin resistance in China in recent years and wondered if a new mechanism, spreading such resistance from bacteria to bacteria, could have emerged. Taking samples from pig slaughterhouses, retail meats, and 2 tertiary hospitals, they discovered MCR1, the first ever documented finding of plasmid-mediated resistance to colistin, a finding that sent shockwaves through the global medical community. Colistin is seldom used to treat systemic infection in human medicine because of its known toxicity, except as a last resort. But polymyxins, of which colistin is one, is the 5th most commonly sold drug for food animal production across 19 European Union countries where such sales data are available. And in the past few weeks, news that the first such case of colistin resistance has been found here in the United States. That would bring the number of countries now with documented colistin resistance in either food animals or humans to at least 20. The UK AMR review touches upon antibiotic use in agriculture in several of its recommendations. It calls for countries, 1, to set targets to lower antimicrobial use in agriculture over 10 years, to set restrictions on critically important antimicrobials in food animal production, to improve the transparency of antimicrobial use in the food industry, to develop a global surveillance network for monitoring antimicrobial resistance in food animals, to increase the use of vaccines and other alternatives in food animals, and to further strengthen the veterinary workforce, so critical to managing effectively the use of these drugs in food animal production. The growing tripartite collaboration among the World Health Organization, the World Organization for Animal Health, and the Food and Agriculture Organization is an important touchstone. We all must begin working across sectors and with a One Health approach on these issues. On these issues, we turn to Steve Roach, Food Safety Officer for the Food Animals Concerns Trust, Professor Jaap Wagenaar, Professor of Clinical Infectology at Utrecht University in the Netherlands, and Dr. Yong Kim, Director of the Animal Health Management Division for the Ministry of Agriculture for Food and Rural Affairs of the Republic of Korea. I'll begin with Steve Roach, a senior advisor for the Keep Antibiotics Working Coalition and as a member of the Antibiotic Resistance Coalition. Mr. Steve Roach brings an important perspective informed by his roles as Consumers International's representative to various Codex Alimentarius committees and as a member of the WHO Advisory Group on Integrated Surveillance on Antimicrobial Resistance. Steve?
Yeah, I would like to thank the organizers for inviting me here today. And I'm going to present a perspective from civil society, or as we kind of see ourselves here as consumer advocate organizations on antibiotic resistance and its relationship to animal agriculture. As Professor So mentioned, just recently, starting last November, we found the detection of colistin resistance in food animals, in food, and in sick patients. And this was did send shockwaves around the world, and it's just been a couple weeks since we had the first human patient reported in the United States. And at the same time, there was a report of a case, transmissible colistin resistance, also found in a pig in the United States. So the food-animal connection is definitely there. But this is just the last of a long line of resistance that we didn't expect, but then ended up finding in food animals. For a long time, we were primarily concerned about ampicillin and tetracycline resistance because these were the drugs that we used to treat infections like Salmonella and Campylobacter that you were likely to get from food animals. Then starting around 2000, we started finding resistance to Cephalosporins and Fluoroquinolones. These were the drugs that you used because you expected that you were going to already have your Salmonella was going to be ampicillin resistant. So we'd switch to cephalosporin and Fluoroquinolones. Now we've moved on to, now we're finding if you have resistance to those two, where do you go to? And where you go to is carbapenems and colistin. And now we find resistance in food animals and in food to both of these as well. So it's a big problem. I think the AMR review report makes some good recommendations what to do. Our perspective is generally that we need to use less antibiotics in food production. We know there's a lot of overuse in humans, and there's equally the same amount of overuse in food animals. So one thing we need to do is set targets for reductions in use. And we think that is totally appropriate. Countries where it has been done, and we'll hear some about that, it has shown that it can drastically reduce use. And we can also show pretty clearly when you compare across countries that reducing use can have pretty significant impacts on resistance in food animals, in food, and in sick people. A good example is in the US, we restricted the use of fluoroquinolones in poultry in the United States, something they didn't do in Europe. And if you compare fluoroquinolone resistance in Salmonella and Campylobacter, things you actually catch from poultry, it's much lower in the United States than in Europe. And then there's other parts of the world where it's even much higher, almost you're getting up very high percentages. So setting targets is important, but when we set targets, we really need to be careful that we take care of the disparate impacts. So we don't want to basically bias it so that we're only helping very large producers or multinational corporations. And we also need to think about how setting targets may have impacts between different countries in their ability to produce food. Something we've long argued for is restrictions on use. And generally, none of the groups that I work with say that we should not use antibiotics in food animals. Sometimes we're misrepresented as saying that. No, but we think there should be targeted restrictions. And there are drugs that probably should not be used in food animals. And from my perspective, colistin is probably a drug we should not be using in food animals. Carbapenems we probably should not be using in food animals. But right now we need to have an international mechanism so that we can develop consensus on what are these drugs. There has been some guidance from the World Health Organization, but I think we need to really set up standards for that. But as well as saying drugs that we shouldn't use, we also need more guidance on things we shouldn't do with most of the drugs. And I think one of the things that has been recognized, and the World Health Organization recommended back in 2000 that we not use these things for growth promotion, basically to reduce the cost of feeding animals. And I think that is correct, but we've also learned that we probably do not want to use those for routine disease prevention either, and that can cause problems as well. And I think in the Netherlands, they found that if you only just restrict growth promoters, it can have no effect or very limited effect. So I think we need strong international guidance. Later this month, there will be a Codex Alimentarius meeting, and there will be a decision whether Codex will move forward with other actions related to antimicrobial resistance, and I hope that that does move forward. But I hope that we can get out of Codex in the coming years actually stronger guidance saying do not use these drugs for these purposes. So also transparency is very important. A lot of the groups I work with, we have done campaigns targeting fast food companies, asking them to develop policies on antimicrobial resistance, and you may have heard of that in the news. We've had, over the last year, we've had numerous of the United States-based companies making commitments to reduce antibiotic use in their meat suppliers, and I think that can be very helpful, but it really needs to be put in the context of, it's helpful, it moves the ball, but we really think we need strong international standards and also regulations in countries. And sadly, there was a recent OIE report that 110 out of 130 countries surveyed basically found they do not have adequate regulation of use of veterinary drugs in their countries. So I think that's a very big problem. Monitoring is important, but monitoring really needs to be useful for doing something. We don't just want to monitor, we need to guide, use monitoring to guide actions and take actions and see how well our actions are working. So thank you.
Thank you, Mr. Roach, for sharing these important framing perspectives. Next, from the vantage point of a country where the second largest export trade of agricultural products in the world, Professor Jaap Wagenaar will offer reflections from the Netherlands' experience in reducing antimicrobial use by 70% in the agricultural sector.
Thank you. I'd like to thank the organizers for inviting the Netherlands to present our successful program on antimicrobial usage, reduction in animal production. Less than a decade ago, there were a couple of triggers in the Dutch Agricultural Society that made the basis to develop a program and a policy to reduce antimicrobial use in animal production. One of the triggers was the publication of two publications, and one was that in the Netherlands, at the human side, the prescription is almost the lowest when we look to European countries, whereas at the veterinary side, animal side, we were the highest compared with 10 other European countries. That was really a signal that something has to be done at the animal side. Other triggers were the emergence of the development of resistance bacteria in the animal production. And for example, the MRSA was an example, livestock-associated MRSA, and the risk of transfer to humans through the food chain, to the environment, or through direct contact. There was also a more general concern about the intensification of our production in the Netherlands. And one of the not AMR-related issues was the largest Q fever outbreak related to milk goats. And that gave in the society a real concern about our animal production. And our animal production is large. As said, we are the second largest exporter of agricultural products in the world. We have a huge animal density on a very small surface. We are only 1/10 of the state of California. Finally, we decided to do something, and that is all based on the precautional principle. So we do not have quantitative data what the attribution is from the use in animals on the problem in humans. But there was we did not stop with doing something. So everybody who was acting had that as a starting point, the precautionary principle. What are the key elements of the reduction policy? First, the ministry set the reduction targets. So they said to the animal production in 2011 only 20% less, in 2013 50% less, and in 2015 70% less compared to 2009. They ask for a full transparency so that we know from all the animal production sites how much antimicrobials they are using. We installed the Veterinary Medicine Authority. That's an independent body that set the targets for the animal production. So what is allowed to use in the different animal sectors. And when we started with that, we simply had a distribution of farms and their ADDDs, so what they use in their animals. And we simply set as a target the 25% highest users should act immediately and reduce their antimicrobial usage. There is self-regulation by the private sector, and there is public surveillance and enforcement of the law by the government. But the self-regulation is extremely important. It's organized by the production sectors. And what I said about the red farms, the farms that use too much antimicrobials, when I give an example of that, that's in the dairy industry. When a dairy farmer uses too much antimicrobials, it's above the target, then the dairy company, the dairy factory, said to that farmer, we will not accept your milk any longer if you do not reduce the antimicrobial usage. And that's a very good economic incentive for a farmer really to act. The government, the role of the government, they set targets, what I said, the 20, 50 and 70% targets. They had a stringent enforcement of their law. And the laws, there were new laws, was the ban on prophylactic use, the fact that antimicrobials can only administered by veterinarians and only in very exceptional cases and very strict conditions there are exceptions for that with farmers. And there is a susceptibility testing when they want to use the critically important antimicrobials like Fluoroquinolones and the third and fourth generation Cephalosporins. And not simply doing an antibiogram, but showing that there are no alternatives possible there. Then the effect of the policy. We managed to have a 65% reduction in antimicrobial use in animals, the sales data, from 2007 to 2014. And compared with the reference year of 2009, it's 58%, 2009 compared to 2014. And the use of Fluoroquinolones and Cephalosporins are reduced to really a few kilograms in the whole animal production. We are now in the middle of, or maybe even the lowest part of the usage in animal production in the Netherlands, or in Europe. We see the effect on the reduction in resistance in our surveillance system, in the commensal E. coli. So we really see the effect, usage followed by the reduction of resistance. The key factors for success were the actions taken by all the parties involved, and meaning commitment from the industry, the government, veterinarians, scientists, and the Veterinary Medicine Authority. We had a One Health approach, collaboration between agriculture and public health, really on all levels, on ministerial level, but also scientists and other organizations. A prerequisite is that the private sector is well organized, enabling public-private cooperation, and we use their production chain quality system to have their self-regulation in these animal production sites. The summary is, there is a huge reduction, is possible, and is feasible, and it also shows that there is a reduction of resistance. There is a change in the attitude of Dutch farmers regarding the use of antimicrobials, and they are not any longer using antimicrobials as a management tool on their farms, but they change to biosecurity and vaccination. So the reduction has shown to be possible in a country where a very large and intensive livestock sector is present. We are the second exporter of agricultural products in the world. We like to do that in the future, and it's possible with less antimicrobials. Thank you.
Thank you, Professor Wagenaar. I would also point out that the experience and exemplar of the Netherlands is mirrored among some of its European community neighbors, including Sweden and Denmark, of course, which have also made impressive progress on this front. And I will now invite our final panel speaker, Dr. Yong Kim from the Republic of Korea, to offer his remarks on the experience of his country in implementing policies to curb antimicrobial use in food animal production.
Thank you. It's my great pleasure to give you our experience regarding AMR, especially at the animal sector. When it comes to AMR, let me go back to 2002 and 2003. At the time in Korea, there were lots of controversies among the public and the media regarding misuse and overuse of antimicrobials in livestock sector. One of the consumer organizations opened their survey result that by the press release that 18 major food, including beef, pork, and fisheries, were heavily contaminated with multi-drug resistant bacteria in Korea. 100% of Salmonella isolate showed resistance to one or more antimicrobials. Furthermore, 63% of Salmonella isolate showed resistance, even 4 or more. And the theories of AMR issues hit the headlines in most of our mass media. In 2003, the government launched the Intergovernmental and Multidisciplinary National AMR Management Program, which covers both human and non-human sector. Based on the program, the government carried out 10-year period national project on AMR from 2003 to 2012. Main activities of the project includes organizing national advisory committee, developing a monitoring program on antimicrobial consumption and resistance in clinical livestock and fishery sectors, implementing of risk management measures on AMR in livestock sector and fishery sectors, investigating AMR in foods, establishing the national surveillance network, and so on. In terms of the main barriers to combat AMR in Korea, firstly, there was strong opposition from livestock farmer organization. They argued if regulation limit the use of antimicrobials in animal feed, the livestock industry would be badly affected due to the increase of production costs, the usage of therapeutic antimicrobials, disease incidence, and so on. As one of the measures to overcome this barrier, the government has been providing financial support to farmers, which are only accredited to comply with relevant regulation on prudent use of animal drugs since 2009. And the government has been encouraging the livestock industry to apply for good animal practice and the HACCP concept, which need less antimicrobials during production stage. Secondly, farmers had increased the use of antimicrobials in feed and water during breeding, and farmers also get used to inject antimicrobials into their livestock directly after purchase from animal drug store without any veterinary prescription. In 2001, it was 45%, but 2007, 55%, and even in 2011, it reached 78%. To make it worse, at those times, there was no significant veterinary oversight system. To overcome this barrier, the government introduced several measures, such as phased ban of antibiotics in feed and phased veterinary drugs prescription system. There are two main actions of AMR controls in livestock. One was to strengthen the national monitoring program. Due to that, the government established the Korea Veterinary AMR monitoring system in 2003. And the other one was to implement more strong regulation on antimicrobials. In 2004, official AMR committee decided the ban of antibiotic addition in animal feed by steps. Before 2005, 44 antibiotics were allowed in animal feed. In 2003, only 16. And in 2009, only 9 were allowed. And finally, in 2011, none of antibiotics were allowed in animal feed by regulation. During the period, there had been strong and consistent push and support from the public, in particular from the consumer organizations. As a result of the past antibiotics ban in commercial animal feed, the consumption of antimicrobials in livestock sector has dramatically been decreased between 2007 and 2011 from 1,500 tons to below 1,000 tons. 1/3 has gone. Some recent studies shows that resistance rate of E. coli isolated from healthy animals and the animal carcass against tetracycline, streptomycin, sulfonamide had been decreased between 2007 and 2015. And also the Enterococcus species and Campylobacter jejuni showed a similar trend. At this time, there are many potential problems in dealing with AMR methods in Korea. For example, increase of usage and resistance of therapeutic antimicrobials, in particular Fluoroquinolones and third-generation Cephalosporins, increase of disease incidence in pigs and chickens could drive increase of antibiotic use, and so on. Finally, I would like to mention the way we are moving forward on AMR. I think that the effective, persistent, and strong intergovernmental and multidisciplinary leadership is essential to combat AMR. We need more extensive monitoring system on AMR. We also need to strengthen laboratory capacity building and a wide range of basic studies on AMR as well. Secondly, I think proper use and less use of antimicrobials are key approaches. So that we can focus our resources into strict control for antibiotics use, residue control in edible animal products, effective disease control at farms, improving of public awareness of AMR. AMR issues is one health issues which are closely related to human, animal, and environmental health. So cross cooperation is necessary in combating AMR not only at national level, but also at international level. Thank you.